As Dr. Joel mentioned, I am going to talk about how we can modify an arbovirus cohort to answer some of the COVID-19 questions. This is the epidemiology team. We are part of the CDC office located in San Juan, Puerto Rico, but I want to share with you this photo of my team because they are the responsibles of implementing the community cohorts. Puerto Rico is an incorporated territory of the US. It was colonized by Spain in 1493, but acquired then by the US in 1898 after the Spanish American War. And they do have a representation in the Congress, but without vote in Congress and without representation in Senate. It has 3.4 million inhabitants. And in 2019, this was a very important year with regards to activity in the Caribbean, and the Americas, but there was not a single case in Puerto Rico of dengue. Puerto Rico had several epidemics on arboviral diseases. On the blue line, you can see the dengue epidemics. They have a sort of cyclic pattern. In gray, in 2014, you have the chikungunya, and in orange, you can see the Zika that started by the end of 2015, spiking then and ending in 2017. And as from 2014 onwards, there has been very low dengue transmission in Puerto Rico, but in 2020, we have 333 cases confirmed by PCR, so it seems that this would be the beginning of a new dengue epidemics. We do not have many tools in Puerto Rico in order to fight dengue. This is a study to the resistance to different disinfectants and insecticides. And you see that in the different rows, the different insecticides that were assessed in the area of Ayamu, Carolina, and San Juan. And the values that you see, the figures that you see here, is the mortality of those mosquitoes when they were applied with these insecticides. So none of the insecticide clearly showed a great susceptibility according to the WHO guidelines. So currently, we do not have tools in order to fight mosquitoes in Puerto Rico. And I want to share with you the COPA project, which means Organized Communities for the Prevention of Arboviruses. According to the Spanish acronym, this is a collaborative project between the Ponce Health Sciences University and Ponce Research Institute, the Vector Control Unit from Puerto Rico, the VCU, and the CDC. The objectives of the COPA program are to determine the efficacy of the Wolbachia suppression in reducing the incidence of arboviral infections, also to determine the efficacy of Wolbachia suppression reducing adult female Aedes aegypti population densities, and we want to measure and assess the effect of local human mobility on arbovirus infection risk and on the effectiveness of this new technique with the Wolbachia to reduce that risk. This is the design of the study. Population is residents of the 38 clusters in the municipality of Ponce in southern Puerto Rico. The intervention will be with the Wolbachia suppression, and we will compare this with the current best practices, which is occasional spraying with insecticides, and there are also educational campaigns for source reduction. And the outcomes that we will be studying are the incidence of arbovirus infections, the incidence of arbovirus disease. We are also studying acute febrile disease and the mosquito population. We heard Dr. Ramand early this morning talking about this technique on Wolbachia suppression, which is different from the replacement technique with Wolbachia. Here, we only release male mosquitoes infected with the Wolbachia, and as you know, the males do not bite. This is a technique of sterile mosquito, and the Wolbachia bacteria is then transferred to the Aedes aegypti. We breed the mosquitoes in an insectary, and for the technique to be effective, we release a huge amount or a huge number of mosquitoes. When these mosquitoes with Wolbachia reproduce or they get together with the female mosquitoes, the eggs are not viable, and thus we reduce the total population of mosquitoes in the community. We've selected 38 clusters, as I mentioned, and this will be randomly assigned with either clusters of intervention or control clusters, and we are following a group of 3,800 residents between 1 and 50 years of age. And to be part of the study, we visit the homes or we invite them to come to the study site. We ask them about demographics, their health, whether they have had fever in the last 7 days or in the last year, and what are they currently doing in order to avoid mosquito bite. And we also ask about the acceptance of the different mosquito control strategies, and we draw blood that we test, and we surveil acute febrile disease, where we included fever, cough, and other symptoms due to the COVID pandemic. And there is an entomological surveillance strategy. These are the components of our project. To involve the community is vital to perform this assessment, because we want to be sure that the community understands the rationale of this, understand that the male mosquitoes do not bite, that it is a safe technique, and that the residents and the different key partners, as the municipality, for example, must support this. Then we have the active surveillance due to arboviral infections, and we randomly take a sample of blood in order to test it. And then we have the entomological surveillance of the octocidal gravic ovitraps, the AGO traps, in charge of the unity of vector control from Puerto Rico. These are the 38 clusters from the study that I am showing. You see the Ponce municipality here, where we have a very good coverage of the whole municipality. And these are the tests that we are running. The different rows show what we used throughout year one and what we're using now during this second year. The first year we did PCR in those febrile patients for chikungunya and Zika and dengue. And then we did IgM and IgG for these arboviruses. And now we are doing the PRMP tests to collaborate with Dr. Steve Whitehead from the NIH. Second year, we're focusing in PCR for symptomatic persons We are not doing IgM from Zika and chikungunya because there's no viral circulation in our surveillance systems. And we are going to do IgG from dengue and PRNP and T for those that were positive in the baseline. And we are including also COVID tests in order to determine the incidence of COVID in these communities, and I am going to tell you how we've modified the cohort in this second year. We've been working on this for 4 years now. We've started in 2017. We understood how the communities were organized. We achieved their engagement in 2018. We started with the questionnaires and the samples, and now we are completing the second year of the study, and we plan to start our third year of the study in November 2020, together with but things have changed for the second year. Next slide. We've visited almost 24,000 households. 2,200 were recruited, and we have almost 4,000 participants. Next slide, please. And this is how we have the clusters after our visits, final outcomes of household visits. You can see that 1/3 of the households are not eligible because the Ponce population is an elderly population and there's a lot of migration from Puerto Rico to the US. 12% are vacant and 5% are reported as not eligible as homes. Next slide. And this is the distribution according to age and sex. 1/3 of the participants of this study are under 21 years of age, and we have very active efforts in order to be able to recruit children for our study. But there is a very interesting migratory phenomenon from Puerto Rico and the US, where young couples go to the US and establish themselves in the US. So we must balance in a way what is possible to have information based on the real population on Puerto Rico. And these are some of the results from our first year that basically show they're from 2018. We have as low seropositivity for dengue. There was not a high transmission back then. 16% were positive for IgM Zika, and 1/3 have had a post chikungunya infection, as we see here measured by the IgG. Something to note is how the past infection of the chikungunya and the recent Zika infection vary according to the amount of hours that the people stay at home. And what we could find while doing this analysis is that the proportion of IgG positive for chikungunya increased in relation to the time the people stayed at home. So in the first part of the graph, some people are between 0 to 30 hours at home, others from 30 to 60, and others almost all day at home. They do not go out to work, do not go to school, and the positive proportion for chikungunya went from 28%, 29%, and 39%, and we see a similar trend in the Zika virus. And this data suggests that the risk is higher in those patients that stay at home for longer periods, and that most of the infections happen in the surrounding areas to the households. So, this is a very interesting finding. Next slide, please. And this preliminary data that we've obtained, this is a collaboration with Steve Whitehead from the NIH to perform PRNTs throughout all of the samples. This is in the population between 1 and 16 years of age, and it shows that by 16 years of age, almost 60% of the participants have been infected with some type of serotype. And we are still working with the University of Florida in order to determine what would be the ideal cutoff in this PRNT test. That, as you know, it's a very complicated one because we have some cases that have cross reaction with the Zika virus. And these cases that appear as seropositive in years age 1 or 2, they might be infected by Zika virus, and we have a cross reaction. Next slide, please. Our second year, things have changed a little bit. Our personnel has to perform interviews with face masks and PPEs. We cannot visit all the households. So we started performing interviews conducted by phone, and we have a very active social media presence. We had to establish a mobile outpatient clinic so that people could come to have their blood drawn here. And you see here the COPA personnel with the full PPE, so as to be sure that our personnel would be protected and that we could continue with the study. We also established active surveillance of acute febrile illness and cough. And as part of this, we were offering the COVID test. Second year of our study, then, we have 3,800 participants. We're still recruiting 5 out of the 38 clusters. And some acceptability data, 83% of the residents in those areas that we work support the Volvakia release, and 85% of the participants also support this. We have an overall retention rate of 70%, and this in spite of the hurricanes, of the earthquakes, and now COVID. So we are working so that the entomological surveillance is high. And in the slide that you're seeing, you see all the figures of our entomological surveillance. And just to mention that we have variability from one cluster to the other with regards the sample of the mosquito population, and also according to which years we do the study or we take the samples. Between June to September, there is an increase in the curve because there is also an increase in the mosquito population. The Wolbachia release started in September 2020. The mosquitoes are shipped from California because we do not have a facility to breed mosquitoes in Puerto Rico, so they are sent by plane 5 times a week, taking them to Ponce, and then they are released in a van that I'm going to show you in the next slide. And we are releasing almost 2 million males per week, and according to the entomological surveillance, this number of mosquito release would be enough. But the survivability and longevity tests are showing that things are going good. This is the bath that we use with the for the Volvakia. The Behring pharmaceutical helps us with this. They have created this special van with these tubes that are for the Volvakia release. And of all the challenges that we can have as a research team, we faced them in Puerto Rico this year because we had Irma, the Hurricane Maria, social movements, riots during the previous government, then the earthquakes that the southern part of the island suffered, and now the coronavirus pandemic. But we have a fantastic team, both at university and at the Unity of Vector Control, and we have continued working. And now I would like to share with you the findings of how we adapted this cohort in order to answer questions on COVID-19. The objectives were to determine community seroprevalence, incidence, and household attack rates of the SARS-CoV-2, to describe the clinical symptoms, the frequency of the hospitalization, and whether there are differences according to age or sex. And the COCOVID objectives are to determine the percentage of asymptomatic COVID-19 infections and for how long the COVID is detected in nasal secretions. The design is very similar to the COPA one. We have a subsample of 1,000 residents, and we've selected households with at least one member under 18 and over 15 in order to have representation of these age groups. We have a weekly questionnaires on acute illnesses. We collect nasal swabs and serum samples at 6 months and 1 year in order to measure IgG for COVID and to determine seroprevalence. These are the same clusters that we use for the COPA, but in light blue and in pink are the clusters selected for the COCOVID, where we are actively recruiting. The COCOVID activities are the recruitment calls to explain the study, determine eligibility, obtain consent, and conduct interviews. We then have the baseline visits for the blood sample collection to answer questions and to explain and observe the nasal swabs. And then the weekly pickups and drop-offs to meet participants at house or drive-through site, receive and scan in the weekly nasal swabs, and review the weekly questionnaires. And we also have surveillance on those people that have either fever or cough. If these symptoms are reported, we then perform an additional nasal swab for PCR for COVID and a blood sample for PCR for dengue. We still surveil for viruses. We also have data review and entry. And there are a lot of people preparing all the kits in order to hand them out. And these are the recruited persons, more than 508 participants, more than 3,300 weekly nasal swabs, and 33 people reported symptoms. Out of these 33, 3 were positive for COVID. Most of the COVID cases have been centered in the San Juan area, and we hope that now that there's more mobility from one place to another, the COVID cases might also increase. Next slide. So in summary, thank you very much for giving me the opportunity to share with you this assessment about the evaluation of the Wolbachia suppression technique and its impact on dengue transmission, and how a research platform like COPA will allow us to evaluate other public health threats, as for example COVID. We are still starting with the COVID cohort, but we want to have 1,000 participants and follow them for more than a year. And in the future, the cohort may help monitor the vaccine effectiveness also. Just to as closing remark, this is an effort not only of my epidemiology team, but also of the dengue branch, of the laboratory staff, the entomology staff, and the Boston Sciences University, where we have also principal investigators and the vector control unit directed by Dr. Grayson is also important part of this. Thank you very much.